Hello everyone. My name is Einat. I'm the clinical manager for the Toronto Central Behavior Support for Seniors program that is based at Baker's Health Sciences but serves the Toronto Central region. For those who are new to rounds, I just want to welcome everyone and let you know the behavior rounds occur on a monthly basis on the third Thursday of the month from 2 to 3 p.m. The purpose of these rounds is really to bring together stakeholders from different sectors to share knowledge, tools, and best practices, and also to promote integration across sectors to benefit our mutual and vulnerable clients that we all serve together. The rounds reach up to 50 different sites across the province and are sponsored by the Behavior Support for Seniors program, TC-LIN, and the Center of Learning for Learning, Research, and Innovation. The success of these rounds is I would say, truly a system effort of multiple knowledge brokers, clinicians, healthcare workers, researchers, and leads across the sectors that really are coming together to contribute and share from the knowledge and expertise. I want to take this opportunity to continue and invite sites to participate and present at rounds and to share their great work and innovations. I'm happy to post my email if you do have any requests or suggestions for something that you would like to present. Please do contact me. Before we move on to the actual topic for the day that I know a lot of people were very excited about, I would like to let you also know that we are recording the rounds and we are archiving them for later viewing on both the Center for Learning and Research and Innovation website, but also the BSO website. And we will post the links for those in the chat. Also, I want to let you know to expect that towards the end of rounds, when we transition into the discussion section in the kind of 15 to 10 last minutes of rounds, we will be posting 2 quick poll questions to collect your feedback. We will also follow it by a more in-depth survey that we will send your way. We really rely on this feedback to improve these rounds and see that we have met everybody's needs. And so we will really appreciate if you took the time to fill them out today at the poll and later by email with additional questions. We're also parting today from Stacy Guy, from the Center for Learning, Research and Innovation, who have been digitally and efficiently, and I would say gracefully, coordinating rounds in the past year. And Stacy is leaving on mat leave. And I wanted to really thank you, Stacy, for your contribution and hard work. And I wish you all the very best for a smooth transition to motherhood. But I also want to welcome Salma, who will be taking her place in supporting rounds. So Salma, maybe you can put a few words into the chat to introduce yourself. We do have a great topic today that is specifically close to my heart, I would say, because of my background in intellectual developmental disability. We're going to talk today about aging and dementia with intellectual and developmental disability, and what people with IDD can teach us. I have the pleasure of introducing our speakers for today. The first one I will introduce is Tara Resnick. Tara Resnick is a psychogeriatric resource consultant with the Psychogeriatric Resource Consultation Program of Toronto. She's based at the North York General Hospital. Tara has over 11 years, over a decade of experience in the field, as well as an extensive knowledge and experience in both the long-term care and community sectors. She has a passion for dementia care and supporting frail adults and their caregivers. She has extensive knowledge in behavioral management as well as cognitive and mental health disorders. She's very passionate about education and helping support staff in providing exemplary care and services to older adults. Tara has a BA from York University, as well as a postgraduate diploma in social service work, gerontology from Seneca College. Our second speaker is Claire Staniforth, and I'm sorry if I'm not pronouncing it correctly. Claire has more than 20 years experience working with people with intellectual and developmental disabilities. Her most recent passion has been pursuing studies in geriatrics and palliative care so that we can expand our clinical services for people with intellectual and developmental disabilities who are aging in Toronto. She is a provincial trainer for the NTG Canadian Consortium and the clinical lead for the Plus 45 clinic for older adults with intellectual and developmental disabilities at Surrey Place Center. In 2019, her team won Human Rights Award from the City of Toronto for their work with people with seniors with intellectual and developmental disabilities. And last, I would introduce, but not least, Mario Tsokas, who has over 15 years of experience in geriatrics and has been a psychogeriatric resource consultant with the University Health Network, Toronto Rehab since 2009, attending to the knowledge to practice needs of staff for long-term care homes, community support agencies, and LIN contracted agencies in Toronto. Mario has participated in many committees and has helped with the organization of the knowledge to practice workshops and events for the Toronto Central LIN Behavior Support Ontario initiatives since 2012. He has a master trainer. He's a master trainer for the Gentle Persuasive Approaches curriculum, as well as a facilitator for PIECES and a senior instructor in mental health first aid for seniors. There's a lot more I can say about Mario, but I want to leave enough time for the presentations. But as you can see, very experienced presenters with lots of information and knowledge to share with us. There will be a Q&A at the end, so I want to give the stage to our speakers, and please post your questions on the chat, and at the discussion phase, you have the ability to unmute yourselves and ask the questions directly, or again, post them on the chat if you're shy. So without further ado, I will pass on to our speakers. Please, the stage is yours. Thank you for coming today.
And thank you so much for the introduction. So welcome everybody. And I hope we do this, the topic, justice, since it's very near and dear to your heart. So welcome everybody. We will be talking about aging and dementia with an intellectual developmental disability. For the purposes of this presentation, we're going to be referring to the population as the population IDD, because it's quite a mouthful to say intellectual developmental disability each time. So I guess we're very fortunate that the PRC program of Toronto through the RGP and Surrey Place, where Claire is from, to have this collaboration that we have. We met over a year ago, and Claire has been very supportive in supporting long-term care homes in the Toronto Central LIN area that we work with in supporting residents in long-term care with both intellectual developmental disability and dementia. And it really highlighted the importance of connecting with resources because together, when we work together, we can truly support not only patients, residents, or clients in this sector, but also care providers, not only just formal care providers, but also informal care providers in doing what's best for the person. So Surrey Place does specialize in working with persons with intellectual developmental disabilities. And as psychogeriatric resource consultants, we support the capacity building needs and knowledge transfer needs, primarily in dementia and responsive behaviors, as well as mental illness. And we do support long-term care homes and the community sector. So it was quite a great mesh when we met Claire. And we decided to put together this presentation, but not only just this presentation, but also working collaboratively with the long-term care homes in the community and supporting the population. So I say it's really important just to really connect with the supports that do exist. So we're gonna have a little poll. We want to get to know who is on the call here. So if everybody has a smartphone, just get your browser ready. We're gonna take a quick poll on Menti or Mentimeter, just to kind of get to know, an idea who's in the room here or what experience people have. So, on your browser, whether it's on your smartphone or on your computer, if you could go to www.menti.com And when you go into this website, just type in this code 1956 60 and 4. And we would like you to answer these questions. Something to keep in mind, this poll is totally anonymous, so please feel free to put your answers in. It's not going to be traced back to anybody. Oh, and here it's already coming in. All right. Okay, excellent. All right. I think everybody can see the live results here coming in. People are answering, so okay.
Mario, for me, the slide is appearing very big, so I'm not seeing the whole screen. I know that people can move it on their own screen as they wish, but I'm wondering if I'm the only one experiencing that, or if we could zoom out a little bit.
I don't think we could zoom out, unfortunately, but are you able to see the poll?
Segments of it.
All right, so most people are saying that it's okay. The poll seems to be okay in most people's ends. Sometimes it's individual technology.
Okay, so I'll figure it out in my end if it's on me.
Sorry about that, Aynette. Okay, so it sounds like most people here in the room here have supported a person with intellectual developmental disability and have supported a person with dementia. I gotta say, what's interesting is, do you feel confident in supporting a person with IDD and dementia? And that's where we see like half of the respondents have put, it's basically halfway. So what we're hoping is, as we go through this presentation and we discuss the population of or persons who have both IDD and dementia, and some of the strategies that you'll feel more confident in supporting a patient, a resident, or a client in the community. Right. So thank you for taking the time for filling out the poll. On that note, I'm going to pass it on to Claire Staniforth from Surrey Place. So Claire, you have the floor.
Thank you so much, Mario. I have to say, it's been really, really fun working together. And it's always fun working with people with intellectual disabilities. They can teach us a lot, and it can be very humbling to work with people who are so challenged and yet can have such an amazing outlook on life. So, Mario, do you want to just fill the screen? There we go. So, I think the first thing to do is to talk about labels and why are we talking about intellectual and developmental disabilities. This is the group of people we used to say had mental retardation. And then we used to say they just had developmental disabilities. And the more research we've done, we realize that you can have developmental disability like cerebral palsy, like fetal alcohol syndrome, or like autism, and yet not have an intellectual disability. So what's an intellectual disability? It's a lifelong disability present before the age of 18. You know what, I'm just gonna turn off the camera. A person with an intellectual disability will score below the first percentile on an intellectual test and will have adaptive skill deficits in the same range. Another way of looking at this is if you lined up 100 people representative of the population, the person with IDD would have more learning problems than 99 of those people. The difficulty in talking about people with IDD is this is not a homogeneous population. There are hundreds of genetic abnormalities and environmental factors that may be responsible for a whole range of strengths and deficits. People with Williams syndrome can have a talent for music. People with autism have a social disability. People with Down syndrome can be very social and very stubborn. So if you've met one person with IDD, you've really only met one person with IDD. And if you're interested in specific syndromes, there's a resource at the end that has our primary care guidelines reference, which might be very helpful. So what's the big deal about IDD and aging? Our folks didn't used to live that long. In 1961, the life expectancy of someone with Down syndrome was just 10 years of age. With support and increased overall healthcare, people are living longer, and yet people with IDD are considerably more frail than their same age peers. One Ontario population-based study found that people with IDD in their 50s were comparable to people in the general population in their 80s in terms of their frailty. Yet frailty isn't something we've generally been good at diagnosing in our older adults with IDD, and something that we now focus on at Surrey Place in our work with older adults. Are they at risk of falling, choking, or developing a delirium? Are they at risk for multiple infections? One of the issues is that not all measures that we use in the geriatric population are valid for people with IDD. And one example of this was a woman that we had in the hospital who'd had her leg amputated and was refused rehab because of her MoCA score. Well, I think probably on this woman's best day that she never could have drawn the picture of a clock. So it was really an invalid measure. And so what we said to the hospital is that we have two options here. We can come in and do a RUDAS on her, which she might be able to do. Or, you could interview her PSW about her motivation, her capability, and then try out some of the exercises with her. And we found out with support, she was perfectly capable of engaging in rehab. So when we look at a historical context, not only did our folks not live that long, but for many of them who are aging now, they spent their early years in institutions. Families were told that they were doing the right thing by giving away their disabled children because they weren't going to live that long anyway. We had one client whose siblings didn't even know he existed until their parents died and they had discovered it by his birth certificate that they actually had a brother who was 60 years old. We have two other recent referrals of individuals who were really resisting PSW support. And we looked back in their history, we found out that both of them had suffered extensive and horrific sexual abuse in their institution in their early years. When the institutions closed and we integrated people with IDD into the community, we spent a lot of resources in helping them to build skills to be as independent and integrated into the community as possible. But here we are 30 years on, and our support systems in the IDD sector are unprepared for people with IDD who are aging, developing dementia, losing skills, becoming less independent, and needing more care. So how do we help our social services networks to support people with IDD who are facing increasing challenges so that they can age in place? And how do we support long-term care agencies who have less experience supporting our folks into meeting their needs? In Ontario, we know that the staff ratio of clients to staff is 5-to-1 in a group home and 20-to-1 in long-term care. But right now, there are over 7,000 people in Ontario with an intellectual disability waiting for supportive housing. So we were finding more and more of them are being transferred to long-term care. In fact, one study showed in 2013 a 9% increase in the number of people with IDD being transferred to long-term care. So if those of you who are working in long-term care feel like you're seeing more of our folks in your homes, you are. So how can we support people with IDD who are aging? One way is through alliances between the IDD sector and the geriatric sector. People like Tara and Mario and I working together, or some of the great collaborations we've had between Surrey Place and Baycrest, just to share our resources and our knowledge and to build capacity in both fields. One good question would be, how do people with IDD age in a way that is different from the general population? Generally, we look at a person with IDD who is over 50 years of age, and we add 20 years to their chronological age. And this is due to issues of comorbidities, frailty, and their overall life expectancy. So one really good example of this was a case that a lovely woman that Linus from Baycrest and I shared together. And she was referred because one of her issues was she was really throwing a fit when she had to get up in the morning. And her staff felt that she was perfectly capable of getting out of bed and that she was just being stubborn or behavioral. When in fact, if you added 20 years to her age, so she was 59, if you thought of a 79-year-old having trouble getting up in the morning, you might think, well, you know, maybe they have arthritis, maybe they're in pain, which in fact was the case. And so an easy intervention was to give her Tylenol 30 minutes before she got up in the morning, and the behavior problems disappeared. One of the other things that you see with our clients is they're very used to being, oh, and unfortunately, I didn't realize you can't see the whole, slide. Anyway, our folks are used to lifelong dependency, and some of them transition very well to long-term care because they're very good dealing with schedules. They're much more used to being supported by other people. And the people that you'll deal with who are their advocates tend to be more parents or siblings rather than spouses and children. So some of our best data on the overall health of people with IDD comes from large international studies of Special Olympic athletes. One of their findings was that 31% of IDD athletes were obese compared to 13% of the population. And this is really worrisome if you think these are the ones who are out and being active. Many people with IDD suffer multiple chronic health conditions, which advances their aging process, interferes with their ability to maintain independence, and puts them at increased risk for dementia. Down syndrome is one IDD diagnosis we know a lot about. At Surrey Place, we have over 20 years of data following people with Down syndrome as they age. We know that people with Down syndrome develop an Alzheimer's-like dementia earlier and progress through the disease much more quickly. Some progress from diagnosis to death within 4 to 6 years. Some studies have found amyloid plaques in people as young as 25 years of age, although they don't tend to develop dementia until their 50s. Knowing that up to 90% of people with Down syndrome will develop dementia can lead to diagnostic overshadowing, where we might assume that they're developing a dementia, when in fact, in their 30s and 40s, they're more prone to depression, whose symptoms can look a lot like dementia. So that proper, careful diagnosis is essential. We try and do a baseline psychological assessments on people with IDD in their 20s and 30s, so we'll have a good measure of what their functioning will be like at their prime, and then we can either retest them later in life or use tools like respondent questionnaires such as the NTG to track changes in health and behavior over time to screen for dementia. In a long-term care setting where you may not have access to old reports, asking siblings or members of their family what their loved one was like when they were younger. Could they read or write? Did they have a job? How did they communicate? And communication is something that Tara is now going to talk about next.
Thank you, Claire, and for setting that up. You mentioned earlier about people with IDD aging and going into long-term care. And that's the thing with working with older adults. As care professionals in the community in long-term care, we're used to the culture of treating older adults as adults and not infantilizing them. And when working with a person who has an intellectual developmental disability, care providers quite often struggle because of what they've learned in their trainings around infantilization and treating the person like an adult and not as a child. The thing is, we know that when we're working with older adults, especially those who have dementia, infantilizing them can lead to responsive behaviors. We find that care providers really do struggle with simplifying language when working with an older adult with IDD and dementia, or even with just IDD. The thought is that they don't want to infantilize the person. However, when we are working with an older person who has IDD or IDD and dementia, you may need to simplify language because it may be at a grade level that the person understands. At the end of the day, we're not treating the person like a baby or a child. We are communicating at a level they understand, and that is actually being respectful to the person. So it's simplifying language doesn't necessarily mean baby talk. Something else that we want to be mindful of is when we're speaking to a person, it's not in a way that sounds like in a very authoritarian way. You know, when we think about an older adult, whether they have dementia or not, if they're being told what to do in a very authoritative way, chances are they're not going to respond very well to that. And neither would we at that, if we actually put it, if we actually think about it. So when we're thinking about the language that we are using, we always want to make sure that we are being very respectful to the person. So the example that we have here is like if a person leaves the door open, telling them don't leave the door open versus please shut the door, you may see very different results at the end. Chances are the person will shut the door if you say please shut the door. And the same thing can go even with a person who has dementia as well. If you speak to a person in that manner, chances are we're not going to get the desired result. Also, again, it's always about being respectful. Whether a person has dementia, an intellectual developmental disability, or both or none, we always want to be spoken to in a respectful manner, and it doesn't make that, it's not that much different. It's not that different actually at all from a person who has IDD and dementia or even just IDD. So always speaking to the person like an adult and making the person feel like they're contributing. When we're thinking about choices, people don't respond well to commands such as don't, you can't, stop. So when we're working with somebody who has IDD, it's not that much different again. So thinking about how do we communicate direction and offering choices at the end of the day. The choices are basically we need you to do A and or B. So what ends up happening is you're making them do what you want them to do at the end of the day. However, they feel like they have a choice in the matter. So let's say you need them to take both their, to take a shower or even to take their pills. So you're offering the choice like first have a shower, then take your pills, or first take your pills, then have a shower. At this point, people are both, so people will do both. Whereas if you just say, you know, would you like to have your shower, or would you like to take your pills? Chances are a person might say no. So another thing we got to keep in mind is when we are thinking about the choices that a person may make. Again, going back to the whole concept of infantilizing somebody, some of us struggle with some of the choices that a person might make. So for example, TV shows, books. It might be something that we may not necessarily provide for an adult to watch or do or read. However, for a person who has an intellectual developmental disability, this might be one of their favorite things to do. And again, it probably is at their grade level. So and a good example would be that if your client, your patient, your resident loves a TV show like SpongeBob SquarePants and that's their favorite show, if they're making that choice and we provide them that choice, we are respecting their choice at the end of the day. So when we're thinking about language, you talked about it earlier, I just want to dive into language just a little bit more. When we think about language, we want to keep language plain and simple. And when we're communicating with somebody about choices that they need to be making, it's not choices that they're going to be making long into the future. We're thinking about choices that they can make here and now. Future or abstract choices can be too tough for the person. They understand the here and now more so than asking them to make a decision for the future. When we are communicating and we're trying to get the message across, we want to think about what are we saying and how are we showing what we're saying. It's not only just about the words that we're using, it's our tone of voice, it's our facial expressions, it's our gestures, it's visual cues that we might be using, whether it's objects or pictures. So you want to ensure that what we're saying and what we're showing is matching at the end of the day. Thinking about questions that we're asking the person, avoiding test questions such as the why, how, is really important. It's actually the same thing as when we're working with a person who has dementia. Asking questions like why and how might be confusing for the person, and it's not that much different with somebody who has IDD as well. It's better to ask questions like what and where. These are easier for the person, especially when we can show as well, because again, going back to the visual cues. and always making sure that your actions are matching what you're saying at the end of the day. Consider those consider the body language and facial expression. Can't stress how important that is. Something else that's also very important is thinking about the words that we're using. Is the terminology too medical? Are we using medical jargon? And when we think about jargon, how well does the person understand that? So it's really important to use their terms. So if you want to provide them with medication, we don't want to refer to it as medication or the name of the medication. We want to maybe think about what is the color of the medication, or even what is the effect of that medication. So let's say the person has pain, and this is like, you could say to the person, here's the pill that makes the pain go away. So when the person really reflects to what the result is going to be by taking that medication, they connect with that better. And going back to the jargon, you know, again, thinking about something like, did you have a bowel movement, or it's time to change your incontinent product? I mean, I want us to reflect to ourselves right now. When did we learn what bowel movement means or incontinent product? I can tell you that it was when I started working in long-term care that I learned what an incontinent product was, and that was back in 2005. So if people haven't learned these terms, you know, thinking about using these terms, chances are they're not going to connect with it. So we really want to avoid jargon. Maybe looking at something like saying, like, we're going to change your underpants or underwear or brief. So thinking about more simple terms and not the jargon. Using short phrases, keep it short, keep it simple. And when we are using phrases, it's not about putting out one sentence after the other. It's taking that time to pause between these short phrases to give a person the time to really understand and comprehend what it is that you're saying. And again, one of the key messages is it's not just about what we say, it's also demonstrating as well with the nonverbal. Something else that we need to take into consideration when it comes to nonverbal is the visual cues, such as calendars, daily schedules, or even pictures as well. These really do help communicate the message. I'm now going to pass it on to Claire to talk us about some of the unique ways in people express themselves.
Yeah, and thanks, Mario. That was really helpful. And you know, this is part of the joy of working with our clients is they really have a lot to teach us, and they do have unique ways of communicating. So I'm going to give you some examples of their communication. The first one that comes to mind is Sandra. She was in the hospital ACL for 3 years, and she would, all of a sudden, she would be, and she was very low functioning. She was basically nonverbal, but she would start listing all of these names, and the head nurse was brilliant, and she realized by communicating with the family that this person was listing all of the people who had died in her life. And when she did that, what she was saying is, I'm in pain. And they actually found out that she had broken her leg 3 days before. So when we transferred her to a new living situation, we were able to say, when she starts listing these names, she is telling you that she's in pain. James, this was really interesting. He was referred to us in the fall, and then in the spring they told me, oh, he's absolutely fine, you don't need to see him. And so I went back and I looked at his history, and I realized they were referring him every fall and every spring that he was fine. And then we looked into his history, and again, he is someone who had lost a lot of people, and the anniversaries were in the fall. And so really we needed to just treat a depression in the fall, and then he would do better as the spring came along. Nancy was somebody with Williams syndrome and schizophrenia, and she called the voices in her head Richard. And so when she said, Richard is being mean to me, that meant that the voices were bad and that we needed to adjust her medication. Matthew was an older guy with Down syndrome, and they referred him to us because they said he kept putting on like 3 or 4 pairs of trousers, and they were sure he had dementia. And this is a perfect example of diagnostic overshadowing because he had Down syndrome, and people with Down syndrome have low tone. And so what he was doing is he was giving himself some pressure, which made him feel better. And so our OT just ordered him a pressure vest, and the behavior disappeared. Susie, she was this remarkable little person with Down syndrome, and her worker kept saying, you have to see her. She's psychotic. She's talking all the time. And then when I asked her who's there, she said nobody. And then when I went to visit, I asked them, well, does she hide in her room and only speak to this person? Is she upset by these voices? And she refuse activities and not engage in social things because she'd be doing this talking. And then they said, well, no, if you only saw it, you'd understand what we mean. And so they put on this 1970s disco music, and this tiny little person was dancing her heart out with her imaginary friend. And so, you know, people with Down syndrome talk to themselves. Some of them have imaginary friends, and some of them script the day's events so they can work them through. And the only time this is really an issue is if it makes them anxious or if it makes them afraid. Now, Tara, this time Tara's going to talk to you about dementia.
Thank you so much, Claire. I love those stories. So let's talk a little bit about dementia. We've talked a lot about IDD, and we're here today to talk about this idea of aging with an intellectual developmental disability and dementia. So what is dementia? It's important for us to remember that it's actually not a diagnosis, but rather it describes a set of symptoms. So it's a syndrome that includes loss of brain function that occurs with certain diseases, and we'll talk a little bit about those later. It affects memory, thinking, language, judgment, and behavior. And as we know, it's not reversible. So it's a progressive degenerative disease. As Claire had mentioned with the IDD population, it really isn't that much different with persons with dementia. When we've met one person with dementia, we've only met one person with dementia. And each person's experience with the process is unique to them, which really just speaks to the need, of course, to individualize. So let's talk a little bit about the different forms of dementia. So we're going to start by talking about the primary forms. So Alzheimer's disease is actually the most common form of dementia. Frontal temporal is less common than Alzheimer's disease and primarily affects the frontal and temporal lobes of the brain. Signs usually include changes in personality, behavior, and language, and the frontal lobe of our brain actually acts as our filter. And as such, it is quite common to see disinhibition in folks with frontal temporal dementia. Then we've got dementia with Lewy bodies. So this is where we'll see those Parkinsonian type features with tremors and hallucinations also being quite common. Dementia associated with Down syndrome, 90% of people with Down syndrome will develop a dementia, which is a huge number when we think about it. And then we'll just finish off by talking a little bit about the secondary forms of dementia. So vascular dementia, a result of a stroke or mini strokes, also known as TIAs. Alcohol-related dementia, also known as Korsakoff's disease, which includes confusion and loss of muscle coordination. And then AIDS dementia complex, which can be a result of late-stage HIV and includes cognitive impairment, motor function impairment, and behavioral disturbances. And then lastly, it's really important to note that some people may actually have a combination of these diagnoses. So when we think about dementia, it's not necessarily the loss of one capability like memory, but rather it's actually oftentimes a constellation of losses. And the pattern of losses or symptoms lets us know what type of dementia the person may have, and there actually may be some intersectionality with the losses. So when we think about the different losses that we see commonly in dementia, we see loss of memory. which, as we know, can include short-term and long-term memory. Loss of insight. So those are the folks we're supporting who have absolutely no insight into their own condition. So they don't know that they're unwell. They don't know that they don't know. And those are your residents, patients, or clients who will commonly say things like, I'm not sick, you're sick. I don't need to take a shower, you need to take a shower. Then we've got the loss of purposeful movement. And this can include, confusion with commands such as up, down, left, right, front, back. Those are the folks you may be supporting who are layering all of their clothes in their closet because somebody with loss of purposeful movement may no longer be able to sequence and may not recognize that, hey, I put my underwear on first and then my pants and then my top and then my jacket and so on and so forth. Loss of recognition, important to note that this may include loss of all 5 senses, and the person may no longer recognize objects, places, people, things, and also may not recognize themselves. And this is where we start to see some of that intersectionality. Because when we think of things like memory and environmental perception, which we'll talk about next, and recognition, we can see some common symptoms throughout these. So I'll give you an example, one I always think of with recognition. I had a resident in my past life when I worked in long-term care who no longer recognized themselves in the mirror. When they looked in the mirror, they expected to see a much younger version of themselves. And this was obviously quite distressing for them. So what we did is we actually covered the mirror with pictures of themselves when they were younger, of their friends, of their family, everything that was very meaningful to them, and the behavior went away. Important to remember when we think about this, though, I always like to throw this in, that at night, windows become reflective as well, so keep that in mind. Might be important to cover those with the pictures if you're going to use that strategy. And another thing I just want to quickly touch on when we think about this loss of recognition, and then as we segue into loss of environmental perception, is that, as we know in dementia care, sometimes doing nothing is having a plan. So what I mean by that is if you have a resident or a client or a patient who is actually, for example, talking to themselves or looking in the mirror and talking to someone who's not there, if it is actually engaging and stimulating and making them happy, there's really nothing we've got to do about it. Let them have that conversation. As Claire was sort of talking about earlier on a different topic, it's when it becomes anxiety provoking or distressing that it's time to intervene. So just something to keep in mind. So speaking of loss of environmental perception, those are our residents or patients or clients who may be experiencing hallucinations or delusions, thinking about things like shadows from furniture, so maybe misunderstanding or misperceiving the shadow from a dresser in their room, for example. I had a resident once who thought one of those old school mops with the white cloth at the end that was leaning up against the wall was a little blonde girl. So of course, when the mop wasn't responding to her or moving, she became quite upset. So just doing that quick environmental scan is something important to consider when we're supporting somebody with loss of environmental perception. Loss of language. So important to remember that somebody who's experiencing this loss might experience and exhibit a lot of frustration. So I can give you an example. I had a resident in long-term care who every morning upon admission was the staff were calling a code white every time I was in my office at around 8 a.m. at breakfast. And long story short, he was throwing dishes and hitting and kicking and punching and screaming. And at the end of the day, he was being served tea and he really just wanted coffee. Thankfully, he was able to write and he wrote down, "I hate tea, I need coffee." And if you're a coffee lover, I'm sure you can appreciate how frustrating that likely was. So that's where we can use things like visual cues to help us communicate with the person with loss of language. So, showing the person coffee or tea and letting them point, showing them show plates in the dining room, etc. And then lastly, we've got loss of initiation. So this is also known as apathy, and this is when the person is experiencing that loss of that internal drive or motivation, that get up and go. And as care providers, what we can do is really be that external motivator, and never assume that because they're not doing something that they don't want to do something. They may actually want to, but they're experiencing this cognitive loss and therefore can't initiate. Just circling back to aphasia though, or loss of language rather, as Mario mentioned earlier, it's really important to offer people these choices. And I talked to you a little bit about visual cues, in the dining room, but we can find visual cues in every environment. So they will be your best friends when supporting somebody with loss of language. And it's really important also to note that somebody living with an intellectual disability may have never been able to complete some of these tasks. So we need to look for a change in their existing capabilities to know if they're experiencing a loss. So therefore, of course, it's really important for us to know their baseline as best we can upon meeting them or admission, to be better able to notice these changes and understand if they're experiencing this loss. And sometimes we might need to use different tools to screen for dementia in the IDD population. And we'll talk a little bit about that in our resource section. So we'll spend just less than a moment on this slide. So just thinking about some of the changes we see in the early stage of Alzheimer's disease, remembering that it's most common, and thinking about the IDD population, we may see loss of interest in taking part in activities, difficulties with tasks or activities that used to be done easily, loss of interest, possibly in personal appearance, difficulty following a new routine or learning a new task, communication difficulties, losses track of a conversation or TV show, and difficulty following multi-step directions, possibly getting lost in familiar surroundings, becoming suspicious of other people, and obviously may appear confused or anxious and sometimes angry or agitated. So this is actually specific to folks living with an IDD. I apologize, I didn't mention that. And it can, I think we need to acknowledge that it can be difficult to diagnose if we don't know their premorbid functioning. So again, it is really important when possible to get input from family members or caregivers, or older psychological assessments if possible, which can give you an idea of how this person was functioning at their best and how rapid the progression of symptoms has been. And diagnosis can also be quite difficult because it can look like depression in younger folks with IDD. So thinking about responsive behaviors and unmet needs, we know that we have to regard behavior as communication. So what is this person trying to tell us? When a person living with dementia is unable to communicate with us, their behavior can actually become communication. And it's therefore really up to us as care providers and advocates to look for the meaning behind the behavior. Responsive behaviors are always in response to an unmet need, and the resident's behavior is the clue as to what that need might be. So what is this person really trying to tell us? So for example, if the resident's walking around seemingly looking for something, are they hungry or thirsty or looking for something to eat? Or if a resident with dementia hits us every time we touch their arm to help them get dressed, do they have pain in their arm? So thinking about these different triggers, that's what we really want to think about when we start talking about the physical idea. So it's important to consider any of the physical triggers for behavior. So thinking about things like pain, discomfort, delirium, toileting. So are they constipated or do they need to use the toilet? Thinking about other diagnoses like diabetes. So are their blood sugar levels not stable, and other diagnoses. And then when we think about the interaction triggers, so 85% of the message we send to each other as human beings is actually nonverbal. So is there something about the way that we are interacting with the person that is triggering the behavior? So for example, are our arms crossed? Sorry, I just realized my video's off. I went to show you my crossed arms and I apologize for that. So are their arms crossed? Or, something like a smile can make a huge difference. I'm sending a very different message to you when I uncross my arms and when I smile. Things like forgetting to knock on the door or introduce ourselves. When we think about it being the resident or patient's personal environment or home, none of us really walk into one another's homes without knocking or being invited in, and it's no different for somebody living with dementia or IDD. When we think about the environmental triggers, I spoke a little bit about this earlier, so I won't dive too deep into it, but just really understanding what is in the person's environment that could be triggering the behavior. So doing that environmental scan, is there a shadow? Is the TV set to CP24 and the news stories are causing the person distress? Is there too much happening at once because the person is becoming overstimulated? And then lastly, thinking about social triggers. So AKA life story, it's so important to know the person's social and cultural history in order to provide person-centered care. So for example, have they lived through trauma? So something like abuse or maybe a near drowning. What are their likes and dislikes? I can tell you with certainty, I hate peas. If you've heard me speak before, you've definitely heard me say that because I hate them. So if I hated peas and you continue to serve me peas, I am not a violent person or aggressive rather, but I would eventually need to show you with my behavior that I didn't want those peas anymore and I might throw them at you. And then really recognizing that we live in the most diverse city in the world, really doing our best to know about our client or residents' religious or cultural beliefs. And this, when we think about all of this and all of these different triggers, and we think about responsive behaviors and knowing the person behind the disease, these things are exactly what help us provide that individualized person-centered care. And I will turn it back over to Claire.
Oh, thanks, Tara. That was really interesting and really helpful. So we just thought we'd wrap things up by giving you an example of two of my favorite clients, both with Down syndrome, both older. And we thought we'd just ask you to put in the, read through a little bit about them and put in the chat box who you think has dementia, John or Dawn or both of them. Yeah, and so let me tell you a little bit about them while you're reading about them. John, I call my Down syndrome professor. He actually wears a bow tie. And the first time I met him, he asked me if I knew who Schumann was. And I double took and I said, "You mean the composer?" And he said, yes, his wife's name was Claire. He's very, very high functioning. And, he reads, he loves music, he can recite all of the lyrics to musicals. He goes to the gym all the time. And the other one, Dawn, is 74 years old, which is really fascinating for somebody with Down syndrome. He has mild IDD, he's very frail, he uses wheel-trans, he's fallen a number of times. He has multiple chronic illnesses. And just in the service of the short time we have left, I'll tell you right now that it's actually John who has dementia. So he's, as much as he's really high functioning, he's getting lost right now. He's getting very upset with his caregiver. He's getting into fights with people. He's forgetting people's names. And Dawn, as much as he's, 74 years old and really frail, when I asked him, what time do you go to bed at night? He said 8 p.m. I said, what time do you wake up in the morning? He said, 6 a.m. And I said, when you go to bed and when you get up, do you ever have to get up in the middle of the night to go pee? And he said, yeah, 3 or 4 times. And I said, okay. Do you ever find yourself in the kitchen instead of the bathroom and you can't figure out how you got there? And he stopped and he thought about it for a while and he went, "You're testing my memory." And I thought, oh my God, is he even ours? Is he even got an intellectual disability? And then when I asked him if he would come down to Surrey Place so we could do some more testing together, he said, sure, but I just have to ask Leo. And I thought Leo was his worker, and word of truth, he reaches down into his walker and he pulls out the little tiny stuffed lion and says, "Hey, Leo, do you want to go to Surrey Place?" So this is just an illustration of how different our folks can be, and how, if you don't know what their premorbid functioning is, how how difficult it can be to figure out which one of them has dementia. Okay, so Mario's now going to just show you a few of the resources we put together for you.
All right, Claire. So just before we go off into question and answer period, some resources for you is the National Task Group on Intellectual Disabilities and Dementia Practices, Alzheimer's Society of Canada when it comes to dementia resources. And Claire was mentioning earlier the guidelines. So if you want for the developmental disability guidelines, www.dd.primarycare.surreyplace.ca. And if you would like to make a referral to the program, the 40+45 clinic for older adults at Surrey Place, please email Claire. We're going to be putting our email addresses at the end as well if you have any other questions. And also the DSO, Developmental Services Ontario, their website. And for more resources on dementia, on dementia, the Regional Geriatric Program of Toronto is a great resource. So rgptoronto.on.ca. We're going to go to question and answer period. But if after this presentation you have any other questions, please don't hesitate to email any of us. So a poll will be going up right now, and please, if you could respond to this poll about the presentation, we greatly appreciate it. Your feedback is greatly appreciated. But also, if you have any questions, please post them in the chat. We're happy to answer any questions that you have at this moment.
Thank you very much, Claire, Tara, and Mario, for this presentation. We're almost out of time, but I'm wondering if there is maybe a question or two that we can quickly take. As you said, the poll is online, and we'll appreciate people's feedback. Any comments that people want to share or ask? So we are already starting to get some. How do we enhance communications when masks have to be worn?
So I know actually our speech pathologists and our audiologists right now are using clear masks for people that have difficulty with those kinds of things. And I do know that it is suggested for people that have dementia, if you actually have your badge on that shows you a picture of your face, or you might have to just step back and just pull down your mask just to show them who you are, especially if they have dementia.
So, and I think that's absolutely right, Claire. I just wanted to show you, Mario showing you that he is doing that. He's got his picture on his lanyard. So he's illustrating your point. And I think something else that's really important to remember, just to piggyback off of that, Claire, is even with a mask on, people can tell when we're smiling. It changes our whole face, it changes our eyes. So a smile goes such a long way with or without a mask. And being really cognizant of body language, again, with or without a mask. Because if you've got a mask on and you're talking to someone like this, or you have a mask on and you're talking to someone like this, even just uncrossing your arms is sending a completely different nonverbal message.
Yes, and again, thinking about using different visual cues to really enhance the message. I think that's very important as well, whether you're wearing a mask or not. It's the other visual cues that's really going to communicate that.
The next question is very interesting. I probably don't have time to respond to it, but a person in Eduardo is asking about how to create a supportive home setting environment. They are encountering an increase of responsive behaviors all around in a specific environment, if I'm getting the question correct, and they want to go home. So I think it's a case of transition. Maybe we could you could mention, where should they come for support when they're encountering those behaviors? I'm assuming is this a long-term care home? The person that is asking question, could you unmute and let us know which environment that is? Is it a long-term care home?
Hi there. It's not a long-term care home. It's actually a supported environment, so like a group home setting in Keswick.
Okay.
And the behaviors seem to be hyper-focused around not being able to see his brother. So we're seeing a big influx in responsive behaviors, both physical and verbal, towards staff, and a very big fixation on going home to see his brother. However, due to COVID and those safety protocols, they're not having home visits at this time.
Right. So I would like to encourage you. It sounds like a case that is worth some behavior support expertise and more kind of zoom in or closer look. If you could contact either myself, I'm happy to post so I can maybe direct you through our BSO coordination office or any of the speakers, and all of us can direct you in the right direction for a resource that you can connect and consult for this specific case. You are bringing a good point. What I would kind of allude to is that with this population, there is an increased percentage of sensitivity, sensory sensitivities, which also sometimes arise in transitions to new environments, and I think add a layer to the overall dementia layer. I'm sorry we don't have time. I know that this is an important topic. Please do contact the presenters for any other questions that you might have. A lot of great comments, Tara, Mario, and Claire, that this is a great presentation and was very helpful. So happy to kind of relay that feedback. I want to thank everybody for joining us. This has been a very informative and stimulating presentation that really covered, I would say, all angles of this very complex topic and multi-layered topic. So again, thank you everyone for participating. We will share the recordings online, and please do reach out to us for any other questions you might have. As promised, I'm also posting my email as well. Hi, everyone. Thank you again to our speakers.
Thank you, everybody. Have a great afternoon. Stay safe and healthy.
Thank you, everybody. Take care.